Your membership experience is important to us. That's why we've listened to your feedback, and we are rolling out a new and simplified membership model designed to add value no matter where you are in your career. You can learn more and see details at rheumatology.org. ACR and ARP, where membership means excellence.
Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. Jon Hausmann. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. One of the most interesting and challenging aspects of the specialty of rheumatology is that our diseases can affect almost any part of the body. Think about it. Rheumatologists manage diseases that affect everything from the hair on your head to the nails on your toes. Thus, rheumatologists need to be experts at soliciting symptoms from patients arising from all of these organ systems. And we also need to have a sharp eye and a keen sense of touch to detect any abnormalities in the physical exam. And what's also remarkable about the diseases that we manage is how specific some of them can be. Take vasculitis, for example. Some vasculitides affect only large blood vessels, and often only certain parts of those large blood vessels. Some vasculitides affect small vessels, and while we have small vessels within all of our organ systems, these diseases have a predilection for affecting the small vessels of only certain organs. Or take a look at rheumatoid arthritis. Out of a couple hundred joints in the body, rheumatoid arthritis really likes to affect the small joints of the hands and feet. And today, we'll be discussing a disease that affects a specific type of tissue within the body. That is, the tissue of cartilage. And of course, that disease is relapsing polychondritis. My guest today has a remarkable story. While completing dual fellowships in infectious diseases and critical care, she was herself diagnosed with relapsing polychondritis. And this not only changed her life, but also changed the path of her career. After her diagnosis of relapsing polychondritis, she decided to move to the NIH to complete a third fellowship, this time in rheumatology. Talk about an overachiever, right? At the NIH, she founded the first prospective cohort of patients with relapsing polychondritis. Since that time, she has become a world leader in the field of RP. I mean, just take a look at who's writing the articles for Up to Date. And she's also played a pivotal role in identifying and describing patients with VEXAS. She's an educator and a huge advocate for patients. Ladies and gentlemen, I bring you the great Dr. Marcela Ferrada. Marce, welcome to the show.
Thank you so much for having me here today. Very exciting.
On this podcast, we've spoken about a lot of different diseases. We just finished speaking with a couple of guests about very common diseases, gout, pseudo-gout, and how they became interested. But today, we'll talk about relapsing polychondritis, which I got to say, it's not the most common disease that we see in clinic. How did you become interested in relapsing polychondritis?
That's a very interesting question. So I chose to do critical care and infectious diseases in my heart. And then I was diagnosed with relapsing polychondritis when I finished my training. And I realized that the best way to help other patients with this disease and to have an understanding of the possible mechanisms of this condition was to study relapsing polychondritis. And to be able to study relapsing polychondritis and see patients, I needed to become a rheumatologist because I didn't have the knowledge to evaluate these patients. I mean, you think about it in the ICU, I don't think that we will be looking at the joints. So,
No, I don't even think they use the stethoscope in the ICU, right? They look at the machines plugged into the patients, and I always felt like it was, like driving, like, steering a plane where you have, all these things and the patient is way far away and you don't really get your hands on the patient like we do in rheumatology. So how did you study rheumatology? How did you actually make the switch?
So after I was diagnosed, I was sick for a few months. At that time, what it was making me wake up every morning, like actually get out of bed because I was super sick, was thinking about the disease and learning about the condition. So I was just like, the only thing that I did is it was like reading about relapsing polychondritis for months. And I was like, when you're a clinician, mainly, you don't read about immunology, right? So everything sounds like Star Wars, right? And then you're trying to imagine and the cell and all of that. So then that is what I did, and then I talked to several people that were very, like, there because they're still here, very smart, and mentors that I had over the years at NIH. And I decided that this was the right thing to do and that NIH was the best place to do this, to study RP, because it's a place that is built to study rare diseases, the way that the system works, particularly because of the number of patients. You need to have enough patients to be able to understand the disease, and then they need to go to the same place. So that is what I decided to do, and I did it at NIH because it was the best way for me to start building the program, which I did with the help of Peter Grayson, right? We did start seeing patients under his vasculitis protocol, and that is how we were able to build this large prospective cohort of patients with relapsing polychondritis.
Fascinating. So before you got there, there was no specific program for RP at the NIH?
No. We built it from scratch.
Amazing. And how long has that program been going for?
We started seeing patients the end of 2016. So we saw one patient at the end of 2016, and then we start seeing more patients January 2017.
Got it. And how many patients do you have in your cohort currently?
Without counting the patients that we have seen with the VEXAS, we're seeing like 130 patients, adult and pediatric patients. Yeah.
Amazing. So, certainly relapsing polychondritis is not one of the most common diseases that we see in the rheumatology clinic, actually. And, I'm sure many primary care doctors, maybe never see one, or at least never diagnose it, even though they may be there. So what are some of the clues that, physicians and patients should have when suspecting a diagnosis of relapsing polychondritis? What sort of clinical findings do you feel are most likely or most concerning for the diagnosis of RP?
Right. Yeah, I know. And I wanted to highlight that point, right? That you said that many rheumatologists have not seen this disease. Maybe they have. What is it? And I just think that the diagnosis get missed, particularly for a type of relapsing polychondritis that I think that is a completely different condition, right? So so before we talk about how do you recognize this disease, I think that is important to highlight that this disease is probably more than one. And then we were able to demonstrate that when we were part of the discovery of VEXAS, right? Because the disease is extremely heterogeneous, and that is why we did the study where we identified the different clinical subtypes, because that was going to be the start to trying to understand what is the mechanism based on the phenotype. So the patients that have the saddle nose deformity and the cauliflower ear and subglottic stenosis, those are the patients that you're not going to miss, right? And those are the patients that is the smallest group of patients with RP.
Okay.
That one, elevated inflammatory markers, typical like bad inflammation. And then the second type, which is the type 2, are patients that have mainly lower airway inflammation. And the way to recognize these patients is by evaluating or asking questions about respiratory symptoms. So these are patients that are going to be complaining of a dry cough and then intermittent shortness of breath, often have a diagnosis of adult onset asthma. But when you take a look at the diagnosis of asthma, they usually don't quite meet the criteria, by ATS. So, but it's a very common diagnosis that is sometimes given to many patients that actually do not have asthma by the ATS criteria. So if you're a rheumatologist and then you see a patient that is coming to see you because they have a lot of arthralgias and non-specific symptoms and costochondritis and cough and shortness of breath and changes in their voice and adult onset asthma, then you should start suspecting the type 2 relapsing polychondritis. And those patients have a little bit of ear and nose, but it's not the typical tomato gigantic ear, right? It's more subtle pain, that it wakes you up at night and something like that. Those patients have a tremendous delay in diagnosis, like about 10 years.
Wow.
Yeah. And then the third group, which is the majority of the patients, those are the patients that have very often a diagnosis of fibromyalgia. So those are the patients that are going to complain of weird symptoms, right? So it's going to be muscle pain and fatigue, and that is kind of at the beginning of the disease that they will have these symptoms, and then over time, then they can start having, nose pain and redness or ear pain and redness, and then in this group of patients is where we discover VEXAs. They belong in this group, and patients in this subgroup also have other interesting manifestations that are very unspecific, including dysautonomia and GI symptoms and some skin symptoms. Some of these patients have a diagnosis of mast cell activation, but it's not really there. Some of them, because they have like muscle weakness and other symptoms like that, then they get diagnosed with myasthenia but they don't really have myasthenia. So it's still very complicated, but that is the group that I'm interested in all of them, but I think that is where we're going to find more subgroups.
Got it. So the first subgroup, you said that, it's pretty obvious when they have, the cauliflower ears and the chondritis in the nose. So you diagnose it basically clinically based on what you see, or is there a role for, biopsy or imaging for any of the patients with type 1?
So type 1 is kind of like very straightforward. And I think that the biopsy could be useful in some of the cases, but I think that the type 1 is just like there is no doubt that they have this. It's going to be the typical, I had this ear pain and then I got antibiotics and it didn't get better, and like recurrent otitis externa. And the problem with these patients is that they have such a tremendous amount of inflammation that they have significant organ damage very quickly.
Organ damage of the ear and nose, or organ damage elsewhere?
Yeah, so these are the patients that have the severe, so they have the saddle nose that can happen very quickly. Ear happens completely, damage of the ear very quickly, subglottic stenosis, and the one that I find terrible is the scleritis. So we actually seen patients that have lost their eye because the disease wasn't recognized.
Wow. Okay. And then you mentioned the type 2 with all the respiratory symptoms. So how should we go about making the diagnosis of RP in those patients?
Yeah. So I think that this subgroup is difficult because they often don't have elevated inflammatory markers. But since at the moment the diagnosis is based on clinical symptoms, then I think doing a very complete, detailed review of systems is going to be helpful.
Got it. So again, clinical diagnosis for the group 2.
Yeah, the only one that you can diagnose with a blood test is VEXAS, which is completely different.
Yeah, well, that makes it very hard for all of us, Marcela. I wish you came up with something easier. What about those patients with type 3 that you mentioned? Sometimes get diagnosed with fibromyalgia. What is it that Because you mentioned with the muscle pain and the joint pain and the fatigue. I definitely see tons of those patients. So how should we sort out the ones that truly have fibromyalgia from the ones that may have something else like RP?
Yeah, so I think that again is super important to do the review of systems. And then sometimes patients are not going to tell you that they have ear pain that wakes them up at night, for example, or that they're going to wear a hat and then the ear hurts. And also the characteristics of the joint involvement, right? So like you just need to do a very good history, like the pain, like the typical pain that is inflammatory, right? That it wakes you up and then you wake up with stiffness. And then unfortunately for the diagnosis, sometimes you won't be able to catch the synovitis. No, and then most of these patients will come to you with pictures because many of these patients have been ignored for a long time, and it takes long time for them to have a diagnosis. But this particular subgroup is also very important because in this subgroup is where you're going to also find patients that have magic syndrome. So asking about oral ulcers and genital ulcers, and the concern about magic syndrome is that these patients can have vasculitis.
Talk a little bit more about magic syndrome. Like what does that stand for? Remind me and listeners what it is.
Mouth and genital ulcers with inflammation of the cartilage.
Huh. Okay.
And then this was described in 1985 at UCSD. And then since then, there's been a lot of case reports. We look at our cohort and then compare patients that have magic syndrome with the ones that didn't. And then we found that patients with magic syndrome are different, in terms of the clinical manifestations. They're having more vascular or symptoms, including Raynaud's, and then they can have true vasculitis, aortitis. And I think that that's why it's important to do like a good review of systems.
Got it. That sounds a little bit like Bechet's, like, it's an interesting combination. And then, you mentioned briefly about VEXAS, which you said it's sort of within sort of the type 3 patients, but it's its own entity. Can you sort of go over about how you guys discovered that was a thing? Because it's been, I mean, to me, it's been incredible to see that, from practically from one day to the next, discover this new disease. And there are tens, hundreds, dozens, I don't know, a lot of patients that have been diagnosed with VEXAS, and sometimes even retrospectively. I was just remembering yesterday, I took care of a patient that passed away probably 10 years ago that probably had VEXAS, when I looked at his history and everything that was going on. How'd you guys come about, making that establishing, that disease of VEXAS?
Yes, it was very interesting. I still find it very, again, like Star Wars, right? So then Peter, he evaluated a few patients. So these patients were seen at NIH long time ago under the undiagnosed disease program, and they seem similar in terms of the clinical manifestations. But at that time, there was nothing that was available at the moment to say that these patients were actually connected in terms of proving the etiology, right, of their phenotype. And then David Beck, he's currently at NYU. He came to NIH, and then he was a fellow under Dr. Kastner. And then he started looking at somatic mutations, and he was interesting in particular genes that work in the ubiquitin pathway. And then looking at those genes, he utilized different characteristics or variables that will characterize the genes that will be novel genes, that meaning that they're not described in the regular population, and then specific numbers that will tell you that these genes are pathogenic. And then he found 3 patients that were patients that Peter have seen a long time ago, that have the similar clinical manifestations. So this was a genotype because David found it, by just looking at the genes. But then when he looked at these patients, and he realized that the patients were very similar in terms of their symptoms. And I got involved into this project because one day Peter was talking about this. He was saying like, oh, I think that we may be describing a new disease. And then we found these patients. And then so interesting, there is a couple of patients that had chondritis. And I'm like, what? And then I was asking him more about the clinical characteristics. And then he said like, well, they're male and they have anemia. And I was like, wait a second, this sounds exactly like these patients that we have seen in our cohort. That never makes sense to me. You need to test them. And then they test the patients, and then they were positive. So then we went and then looked at the other patients that were in our cohort. And then we asked the patients to come to NIH and study those patients. And they were included in the original report.
What an incredible story. I mean, it sounds like, I'm sure that what you've been trying to do is sort of unlock the key, right, for relapsing polychondritis. Like what is driving this? And at least sounds like what you found is, in a subset of patients, you found the key, right? You found that there is this somatic mutation that causes all of the symptoms that these patients are experiencing. That must have been, pretty incredible to have and to be a part of that study.
Yeah, it was amazing. And it was like such a nice collaboration with like intramural and extramural. It was very nice. And then just to be part of the process, when you're describing things. And then it was very interesting to me when I was going through all the charts because I took care of the clinical description of these patients. So I was making a list, right? And I was like, pulmonary infiltrates. They have this. So it was very cool. And then for the RP community, and as a patient with this disease, it was a big deal. It is a big deal because then again, it's a proof of concept that this is more than one disease, right? And then we found, as you were saying, the key for 8% of the patients in our cohort. So then we need to find the rest.
So what? Yeah. So of patients diagnosed with relapsing polychondritis, what percentage do you think may have VEXAS? Is it 50%, 20%, 10%?
So it is between 8 to 14%, depending on the study that you look. But I think that we'll see what happens over time.
Fascinating. I mean, that story is still so incredible. And I think it's gotten the interest of not only rheumatologists, but hematologists and other people that may be evaluating these patients for their various symptoms, because it seems like it's a disease that causes symptoms in many organ systems. And it's great that people are learning about it and asking about it and interested in learning more. So for the diagnosis, I mentioned that, I saw a patient 10 years ago that may have had it. People currently that, suspect that their patients may have VEXAS, what are the clinical manifestations that we should be aware of? And how should we go about making the diagnosis? Like, where should we send the genetic test to?
Yeah. So it is more common in males because it's X-linked, but females can also have VEXAS. And the age range so far, we have identified these patients in an older population, but I suspect that is going to change. The patients that we have seen have a lot of symptoms, and I also think that is probably a referral bias. And then just because the patients that we initially evaluated that have such an advanced disease, so then they have pulmonary infiltrates and fever and tremendous fatigue, DVTs, skin lesions, chondritis, right? So they have all of these symptoms, and then that is how we put all of this together. But I think that to identify these patients earlier, you should suspect that a patient may have VEXAS if you start seeing that the MCV is a little bit on the higher side and the inflammatory markers are elevated and the patient have some like systemic symptoms, or maybe they're not even have symptoms at that time, right? So then but I think that is going to take a lot of time for people to recognize, and probably more for the primary care. For the rheumatologist, I think that if you see a patient that have unknown inflammation, you should suspect VEXAS if it's ML more in the 40, 45 age range. And we did an algorithm for patients, particularly for patients with relapsing polychondritis, and we found that in a male patient that has ear and nose chondritis and then has platelets less than 200 and an MCV more than 100, you have a very high sensitivity and specificity to test positive for VEXAS. But over time, we have learned that that the clinical spectrum continues to expand. So I don't know if I answered your question.
Yeah, no, and so it sounds like if you have a diagnosis of chondritis and you're male and you're on this a certain age range and you have these CBC characteristics, you have a pretty good pretest probability of having VEXAS. But as I understand it, there's many patients with VEXAS that don't experience chondritis as part of their symptoms, right? So in those patients, I guess, the diagnosis may be more difficult in that you have to sort of think about, well, somebody with systemic inflammatory disease, maybe some bone marrow abnormalities that doesn't quite fit any other condition, is that VEXAS?
Right, exactly. So I just think that we just need to have a high suspicion because you don't want to miss the diagnosis. And I think that at this point we are learning a lot about the disease. And I think that why not test the patient?
So how should we go about testing?
Yeah, so there is different commercial places that you can send the test. There is a place called GTC. I can send you the link for this. And then this test, it tests for all the, hematologic genes associated with disease. And then it is covered by the insurance if the patient has cytopenia of unknown etiology. Another place that you can send this is Invitae, but the problem with Invitae is that they are reporting the pathogenic variants as being variants of unknown significance. So that gets a little bit confusing, right? Because it's like, oh, this is in the UBA1 and it's like MED41, but it says that of unknown significance.
And you're like, no.
Yeah. Like it does have a significance.
You got to give them a call, Marcela, and say, hey, you guys, this is actually pretty relevant. Yeah. Great. So if you give us those links, we'll be happy to put them on our website as resources for both clinicians and patients about, how to make the diagnosis of VEXAS. Another question. So we talked about VEXAS, within the RP population, VEXAS in the US. What's going on with VEXAS across the world? Do you have any data? Like, are we getting reports of patients with VEXAS in other parts of the world?
Europe is pretty good, like many of the reports and everything is coming, from the French group and then UK, all of that. And then we actually have a international group where we have been working in, possible recommendations based on the little data that we have. And then with a little bit. So then clinicians can have a little bit of a guidance of how to treat these patients and again the diagnosis and when to suspect and all of that. But an area that I think that it needs more in terms of diagnosis and treatments and access to treatments and developing all of that is Latin America. But we're currently working and trying to figure it out the best mechanism to help with diagnosis in Latin America. Yeah, with the help of course, a geneticist, and then hopefully we'll have a established mechanism.
Fantastic. So it sounds like VEXAS is, maybe a small percentage of patients with RP. How common is RP? Do you have any data about, sort of the incidence or prevalence of this condition, either in the US or the world?
So this is very old. So the first person and the only person that did a prospective study of patients with relapsing polychondritis was Clement Mischet at Mayo. And this study is from 1986. and then he calculated that it was like 3.5 per million. Since then, it has not. We don't have that data, and then one of the issues is that the diagnosis does not get recorded in the charts. So I look at this. We look at the CD9 codes and CD10 codes, and all of this, and it didn't make sense to me, right? I look at the data, and they were like, oh, in this year there was only 150 patients diagnosed in the United States, and I was like, no, I don't think so. That is the amount of patients that we have in the waiting list. So I think that it's going to take a little bit of time to be able to have a number that is going to be accurate. And then again, the other thing is that I think that these patients are not being diagnosed because they're not being recognized, and it is a clinical diagnosis at the moment. So it's very difficult, as we discussed before. So it's being underdiagnosed, I think.
Yeah, I probably agree with you. As some of our more rare conditions, they're rare, but we probably see more of them that we actually recognize. So let's shift a little bit, talking about treatment. First I want to ask you, what specialists should be involved in the treatment of relapsing polychondritis? I actually, diagnosed a patient with RP just a few months ago. I sent them to an ENT who said, oh yeah, this is an immune-mediated condition. You should just go to your rheumatologist. ENT does not play a role. I'm like, okay, that's what UpToDate said to do. So what group of doctors should help to take care of patients with RP? What should be the team?
The team, yeah, maybe we need to find an other ENT.
Okay, good to know.
That maybe, so it is, again, I think that it goes depending on the types. I think that is a good way that to have an algorithm. So patients that have the type 1, and in general, all of them, but I think that the type 1 patients for sure need to have an ENT. And the reason is because they develop very often subglottic stenosis. And then if you don't want your patient to have a tracheostomy, then the ENT can help, with dilatations and injections. And there is an amazing ENT in New York that I have seen, I think, the most patients ever with relapsing polychondritis. His name is Dr. Lebowicz. He's great. So they do need an ENT. The other thing that these patients need in terms of evaluation is audiology evaluation. We have been able to capture hearing loss in some of the patients that they didn't realize that have hearing loss. Yeah, sometimes I said I have a hearing loss, particularly to my husband. I just say, what? Like, I don't know. I have RP. Yeah, so that sometimes could be convenient. But a hearing test for everybody as baseline, ENT, particularly for the patients that have significant organ damage, then a pulmonologist. And the reason for the pulmonologist is because we're still trying to understand or define what is the progression of the disease in some of these patients, because that initial analysis that we did was based on the initial visit. So we need to do the follow-up and then see what happened to them. But it's possible that the patients that are in the group 3 may move to the group 2, right? And then they will have respiratory symptoms and then tracheomalacia or bronchomalacia. It is difficult to manage from the respiratory standpoint because sometimes the stents will create granulation tissue, but that's why they need to be seen by a pulmonologist, an interventional pulmonologist, if they have airway damage.
So should patients routinely, even if they have no symptoms, get, things like PFT or chest imaging?
Yeah, so then they are not really useful in patients with RP. So that is what we learn, in rheumatology, that, you do PFTs, and then if the PFTs are normal, then we're good. No, that's not true. I mean, the other thing is that PFTs were not developed to study or evaluate patients with relapsing polychondritis. These tests were developed a long time ago to evaluate patients with other diseases, right? Asthma and COPD. So they may be different values in the PFTs that sometimes we don't pay attention, because that is what you learn, that the FEV 25 to 75, which is a surrogate for distal airway disease, you don't pay attention. Well, we see a lot of changes on that in patients that have RP. And then sometimes we use that as a surrogate of distal airway. So PFTs will be helpful to rule out true asthma, right? Make sure that this is really, because sometimes you can have RP and asthma, it's a common disease, but not really to say that you don't have for sure, you don't have tracheomalacia.
Fantastic.
Oh, I didn't answer your question. And then CT scan. Yes, I would like to do a dynamic CT scan as baseline, again, because we have been able to capture, abnormalities, that the patients are not tremendous, like having a lot of symptoms.
So dynamic CT scan, that's not the regular, high-res CT. It's sort of inspiratory and expiratory?
Correct. Yeah.
Fantastic. Okay. Yeah, I hadn't thought about that. So it sounds like, you need a team of people to help manage RP in addition to the rheumatologist. And do you see the rheumatologist as the one sort of helping to direct the care and pointing people elsewhere, or how should everybody work together?
Oh, it should totally be the rheumatologist. Absolutely. Because it's the person that will know the patient the most, right? And I think that as many other patients that have systemic diseases, you need somebody that actually understands what is happening in other places. And I think that, unfortunately, if you do, pulmonology, then you're going to look at the lungs, and then that's it, right? And then if you do cardiology, we'll just look at the echo. So I think that the rheumatologists have the knowledge and intelligence to be able to know everything that is happening in the patient and direct where the patient should go.
So you mentioned echoes. Should that be routine for everybody as well?
Yeah, I think that at least at baseline is very rare, but these patients can also have, valvulopathies. We have like a couple of patients that actually have valvulitis. So very rare, but it can happen.
Okay. All right. So we made the diagnosis. We established our team. How are we going to start treating patients with RP? How should we think about the treatment?
Also, like the rest of the things, is very depending on the patient. Right? So we're seeing that patients with type 1, the patients that the small group with the saddle nose and the cauliflower ear, those patients tend to respond well to anti-IL-6 in combination with something else. And then
in combination with something else, meaning what?
Methotrexate or myclophenolate or leflunomide. So you pick your candy, right? It's like a table full of candy, and then you have like so many options.
Okay, but IL-6 being sort of the mainstay, and then addition of something else. Great.
Yeah. So that is going to be like the IL-6 is your cake, and then you can put the cherry. You can just pick your cherry color.
I love the metaphor.
Yeah.
Got it. Okay, IL-6, my new best friend.
Yeah. And then for patients that have the type 2, which is the airway, we also think that IL-6 may work depending on, we tend to look sometimes at the inflammatory markers. So some of these patients have elevated CRP, and then these patients may respond better to tocilizumab. And again, it's important to rule out asthma, because in some of these patients, they may have bad asthma and will need a different kind of agent to help with the increasing the eosinophils and the respiratory symptoms due to asthma. And then the type 3, those are the patients that are more difficult. So that also goes by the different phenotypes. So if you have a patient that have more like MAGIC syndrome, like Behçet's, then TNF may work better. If you have a patient that have like mild RP and just joined, then you can start with a methotrexate, and it works very well. And historically, when you take a look at the studies, from the 1990s, is been a good agent to help with the joint symptoms as you expect with all rheumatologic diseases. But these patients also have other things that are important to take care of, which you were saying, the multidisciplinary team, right? So these patients patients also sometimes, I was telling you, get like POTS and then have all these other symptoms that may not be inflammatory. So they may need to be evaluated by cardiologists or something like that to make sure that there is no other issue that needs to be taken care of. But if, for example, the patient has the diagnosis of small fiber neuropathy and they have myalgias and they have POTS and they have all of these, then IVIG may be a good option for this patient. So it depends on, the clinical phenotype. And then, unfortunately, most of the time you need to keep adjusting the agents because they won't like stay stable for a long time. So that is the other thing. We have to change the name because the concept that this is relapsing sometimes is not true. It's like a relapsing polychondritis. No, I think I would call it like a progressing or something different. Yeah, so it's more than one disease. So I think that it will depend a lot on the clinical symptoms and the manifestations that they have.
What about Vexus? How should we start thinking about the treatment for Vexus?
Yeah, Vexas. You make me think about that. There was an episode in a TV show about Vexas, like right at the beginning.
Yes, I remember. Yes.
Serious. It was like the guy was like, oh yeah. And then we did the genetic testing and then boom, we got the diagnosis. And I was like, oh yeah, really? How long did it take you to do it? Like it took 20 minutes, right? And then he goes like, yeah, and then we're going to start treatment now. Like, oh my God, you have to tell me what is it? Because you have to do that. And I call you and then you tell me what is it that you're using?
We should put a link to that episode for anybody who's interested as well.
Yeah, I mean, I was like, it was just very funny. And I was like, so then, yeah, treatment for Vexas has been a little bit challenging because they have refractory disease. Again, is still a genetic disease, but it's very heterogeneous as well because it depends on the stage of the disease. So you have patients that have more hematologic symptoms, they have patients that have more inflammatory symptoms, and that is what is going to guide your treatment. Is going to be depending on the dose of steroids and the hematologic abnormalities. So you always have to have a hematologist on board when you're seeing a patient with Vexas because you don't know which way the patient is going to evolve, right? They can start becoming transfusion dependent. We believe that the ultimate treatment for this disease is a bone marrow transplant. We actually have a protocol here at NIH, which is a phase 2 clinical trial, and then we transplanted the first patient.
Wow.
Yeah, I know, it's super exciting. He's like 45 days out, and he's 100% chimerism. So basically cure. Yeah, it's amazing. So I think that's important. And then deciding when this patient can have a transplant is what we keep, talking about over and over. As a rheumatologist, the initial treatment is steroids. And then the agent that we have seen a good response is, again, tocilizumab. By the way, I do not have any relationship with tocilizumab. I'm not promoting it. We just use it in this disease, and it appears to work to decrease the dose of steroids.
And sarilumab as well, or is there something special about toci?
It's very interesting, sarilumab, because we try to use that one, and then the patients respond in terms of the clinical symptoms, the inflammation, but they keep saying that around the time of the injection, they were not feeling well, for like 3 or 4 days. So they just have, fatigue and myalgias, and they didn't feel well. And then we switched them to tocilizumab, and that went away. Weird, right? I have no idea why. But yeah, that works. And then the other agent that can work is ruxolitinib, which is a JAK inhibitor, but you can have, a lot of side effects with that. So you need to be careful. And then this medication is mainly used by hematologists. So again, have a hematologist on board. And then TNF, they don't really work. I wouldn't even give it. And then IL-1 also works, but the problem with the anakinra is that these patients can have a tremendous reaction to it. And I suspect...
Like injection site reaction?
Yes. Terrible. Like patients need like a graft. It's like horrible. So then I suspect that this is because the medication is being diluted in this citric environment. So when you actually use anakinra, it's extremely painful. It burns a lot. So I suspect that maybe if you tried rhinolosep, it should not be that bad because rhinolosep gets diluted in water. So the patients that we have seen in canakinumab, for example, have been able to decrease the dose of steroids, but we're always afraid about the anakinra side effects.
Got it. Okay. So in addition to the medical treatment, the medications, all the doctors, I'm sure that patients are stressed out about their condition and are looking for some type of, support. I imagine that most patients with RP probably never heard of the diagnosis before, and most certainly probably don't know anybody else that has a similar condition. What sort of support do you provide patients in addition to, all the medications and the doctors? Where should patients, go for support, to speak with others? Do you have any recommendations?
There is a Facebook support group that is very very good, because then you can relate, to the patients. I did that a lot at the beginning because I was like, this is just weird. I mean, it's like very strange at the beginning when you get a diagnosis of a chronic rare disease. So it's interesting. It's good to talk to other people that have gone through the same process, because then you don't feel that alone anymore, right? Everybody goes through the same years of seeing doctors and all of this, so that is good. And I always suggest to the patients to have also a psychologist or somebody that they can talk to, because it is very hard, not only on you but everybody around you, right? Is your family, your friends, people at work, is very is difficult, very stressful for everybody. Yeah.
Yeah, great. I remember, when I was a fellow, I was speaking with a patient with relapsing polychondritis about, the quality of her episodes. She was saying that she was having episodes where her ears turned, beet red, but she wasn't having much pain. And I commented, well, that's kind of unusual. And she said, no, no, no. Actually, in my Facebook group of, I don't know, 3,000 patients, we all talk about this, and it's actually quite common. So I was struck by how much we can learn from these patient groups. I mean, think about it. If there's 3,000 patients with RP on this Facebook group, that's probably the biggest registry or biggest collection of patients, right, in the world. What a valuable resource to have. And certainly for her, it was, it had been incredible value, incredibly valuable, I guess, as it has been for you. And I like the idea of that you mentioned about taking care of the mental health, because it's not only sort of any depression and anxiety, but also how to cope with all these, medical issues. It's hugely important. And that's something that sometimes we overlook. So what do you see going forward? What excites you about RP? Where's the field moving, and what things are still left to be done?
Oh my goodness. That is a huge list, right? I mean, you're like, oh, there's a lot that we need to be done, a lot, right? So we need to figure out what is the mechanism of the all different types, so then we can help with the treatment. Because I was saying before, you can start them on biologics and all of that, but they continue to have like inflammation. So understanding that is going to be extremely important to help with the treatment. We need to keep working on the classification criteria, so we could do clinical trial, and then that would be extremely helpful, because then your insurance may pay for your treatment, right? Because right now it's very difficult to deal with insurance, right? So if you have something that is approved, then that may be better for the patients. And again, it will is very similar in terms of the treatment for like Takayasu, right? That you have all of these different ages depending of what you use, and then difficult to track disease activity and on all of that. And that's the other thing, the disease activity, right? And then that we're also working on that hopefully soon. Laurent Arnaud, he is the one that did the initial disease activity for RP, and then we're working on trying to modify that, and then keep trying to understand the underlying mechanism. So I think that, and also best ways to detect organ involvement before there is damage, right? Yeah, I mean, and then if you give me time, I will keep talking about it, right? And I can just get into like cartilage mechanics, right? And then how you can get change based on temperature, and all of these things. Yeah.
I mean, one thing that I was just thinking about is, you've identified that for a subset of patients with RP, it's a genetic disorder. It's right? There's a specific gene that causes it. For all the rest of the patients, is RP an autoimmune disease? Like, is there evidence of like autoreactive, T and B cells and autoantibodies? Is this more of an autoinflammatory disease where you have, activation of the innate immune system? What's your sense?
Oh, I think that this is innate, and I think that there is something that is going to be the trigger for this disease that is a constant, and that's why you keep flaring. I mean, it's basically most of the time, or many times, is a constant flaring, at least for the type 3. I'm suspecting that for the type 1, we may be able to find an antibody just because of the significant damage, and then these patients don't have the systemic involvement like the patients with type 3 have. These patients have mainly cartilage, right? They have the nose, they have the ear, the eyes have a proteoglycan, but it's a similar type of protein. So you have the eyes, the nose, the ear, and the joints, but they don't have heart involvement. They don't tend to have vasculitis, or we have not been able to find that. They don't have GI involvement. They don't have POTS. They don't have all of these other issues. So for that one, I suspect that we may be able to find an antibody. We just haven't found it yet. And then for the type 2, I think that is also innate. I'm suspecting that some of the patients in the type 3 will move in the type 2.
Wonderful. Marce, thank you so much for your time, and thank you for everything that you've done for RP, for the RP community, and both for patients, for physicians. I love that you're focusing on helping everybody to diagnose patients, to treat patients better, to have patients live better lives with RP, and it's been really inspiring to see all you've accomplished in just a few years. So thank you, and keep up the good work.
Thank you so much, and it's so nice to see you. I hope I'll see you soon.
Sounds good. Take care.
Bye-bye.
Well, that's it for our show. If we ever get to understand the etiology of relapsing polychondritis or discover an effective treatment, I have no doubt that Marce will have played a huge role in those efforts. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this episode at acronair.org, on Apple Podcast, and on your favorite podcast app. Until next time, look out for inflamed cartilage. And of course, stay healthy.